Good day everyone, I'm Lawrence Lloyd. First of all, I'd like to thank all of you and welcome all of you to this episode of Meeting the Expert. In this episode, it's a pleasure that we're able to invite Dr. Kent Woo, who is a consultant internal medicine specialist and also did his fellowship in allergy and immunology in the United States. So Dr. Kent, welcome to this episode.
Thank you for the invitation.
Yeah, it's a pleasure, Dr. Kent. In this series, Dr. Kent, we have been talking about allergic rhinitis and we have been talking about the basics and also clinical signs of allergic rhinitis. We have also touched about the risk versus benefit of intranasal corticosteroid. However, oral antihistamine have equal importance in the treatment of allergic rhinitis. So, do you really agree about that? That is actually an important thing before we move on?
Yes, absolutely. I think antihistamines are our first mainstay treatment in the approach of allergic rhinitis. We hear it all the time in our guidelines, and also it's being primarily used in the primary care setting. Now, the unique thing about Malaysia is in the primary care setting, it does not just include physicians, it also includes pharmacists. And also, our patients are very, very well aware of what are the treatment options available for allergic rhinitis. And what is more convenient than reaching out for a pill? So allergic rhinitis treatment with antihistamines are actually one of our mainstay first-line therapy for the approach and management of allergic rhinitis.
Thank you so much, Dr. Kent, for sharing a little bit about oral antihistamine. And I noticed that recently you're actually one of the authors in one of the expert consensus that was recently being published with the title of Using Patient Profile to Guide the Choice of Oral Antihistamine in Primary Care Setting in Malaysia. Could you kindly share with us a little bit about how this article actually come about and what is so unique about this article?
Thank you for highlighting this article. This article is actually very interesting. When we looked at articles in the management of allergic rhinitis, it's basically based on guidelines. And guidelines require a lot of evidence-based medicine, lots of reference, and the way that it's presented is generally towards specialists. So it makes for very difficult reading for primary care physicians as well as primary care providers here in Malaysia. Now remember, pharmacists and also GPs form the bulk barebone in terms of giving primary care to our patients here in Malaysia. So the idea came about to write an article that is more based towards primary care evaluation for allergic rhinitis. So that article was designed in a way where it's easy to approach, and we did this unique approach called patient profiling. So that when a primary care provider approaches a person with allergic rhinitis, they're not thinking about it on a disease-based process, but based on a person process. And from there, work out what is the best way to evaluate and treat the disease.
All right, Dr. Kent. The article also mentioned that oral antihistamine or the first generation oral antihistamine are indicated in the past, but currently the second generation oral antihistamine are the most indicated for the treatment of allergic rhinitis and also chronic idiopathic urticaria. Are there any main differences between the pathophysiology of allergic rhinitis and urticaria that are important for us to be aware of?
Yes, I think this article really highlights that the use of first generation antihistamines should really be abandoned. I think the article really goes into details the reason why, and I'll highlight a little bit on the first generation antihistamines here. First is the first generation antihistamines, a lot of side effects. So it crosses the blood-brain barrier and causes dizziness, sedation, dry mouth, and cholinergic symptoms. So those are very undesirable effects of first generation antihistamines. Further on, the first generation antihistamines also have a short duration of action. So these two combination leads us all to now recommend against the use of first generation antihistamines in both the treatment of allergic rhinitis and chronic urticaria. Then the next thing is, what's the difference between allergic rhinitis and urticaria? And why do they need the use of antihistamines, right? Why can you use one medicine to treat two different diseases? Okay, well, first of all, allergic rhinitis involves the nose, right? And urticaria generally involves the skin, right? But the pathways are very similar. They use a histamine generated pathway. So when you have a histamine release by the mast cells in the nose, where they release histamine, that's when you get the itchy nose, the sneezing, the runny nose, and the nasal congestion, mediated by histamines. So using antihistamines work in this situation. In urticaria, the same thing happens, but the mechanism for the mast cell release is a bit different. So in allergic rhinitis is by contact with aeroallergens you breathe into the nose. Urticaria is a little bit more complex. It can be from many other triggers. It could be autoimmune and it can be idiopathic. But whatever the trigger is, the end result is that the mast cells release the histamine. And that leads to itching, and it can lead to the wheals, the flare, the redness that you can see in chronic idiopathic urticaria. And in this situation, using antihistamine works. The main difference between the use of antihistamine for allergic rhinitis and chronic idiopathic urticaria is the dosing. If you see, yes, that is the key. So in allergic rhinitis, usually we recommend single daily dose, the recommended dose. But in chronic idiopathic urticaria, generally the guidelines recommend, if it doesn't get controlled with a single daily recommended dose, we go up to 4-fold the daily dose. And the reason why, and everyone's like, why do we need such a high dose? Well, if you look at it, the skin, the organ, the skin is definitely a larger area compared to the nose, which is really localized over here. So definitely you need a little bit higher dose to suppress the histamine release when you have urticaria all over the body.
Makes a lot of sense.
Yes. Hopefully that helps shed some light in the matter.
Yeah, it definitely helps a lot, Dr. Kent. And the second question that I'd like to follow that is that in the management of allergic rhinitis, oral antihistamines are also indicated as what you have mentioned by the key international guidelines such as ARIA and also IACI guideline. How does the oral antihistamine play a role in this disease?
Yes. For allergic rhinitis, the release of histamine,
like what you mentioned earlier,
yes, causes a lot of inflammatory mediators. So I'm going to delve a little bit into it. Now, first we have to understand the histamine receptor. So the histamine receptor is a very interesting manner. It's either in an active state or in an inactive state. So antihistamine doesn't really block the receptor like we used to
It's
think.
not a direct
Yes,
antagonist.
yeah. So it's called a inactivator. So it's called a histamine agonist that changes it into an inactive state.
I see.
So therefore, these receptors are always on all these cells. And when you have an antihistamine that binds to it, it changes it to inactive state, and so you don't have all the inflammatory mediators.
The downstream.
Downstream effect from the histamine release. So what are some of the things that we see from histamine? You release inflammatory molecules. So you not only histamines, you get the leukotrienes and the cytokine release when the histamine binds to the inflammatory cells. Furthermore, this histamine also binds into the nerve cells. They have a nervous receptor over there, and the nerve cells will communicate to the brain that we perceive as itching. On top of it, the nerve cells, when they receive this histamine, will also mediate release of inflammatory mediators by other cytokines from the mast cells and the inflammatory cells. So histamine is a very, very important signal chemical. So by using antihistamines in allergic rhinitis, you not only block the release of these allergic chemicals from the inflammatory mediators, from the inflammatory cells like the mast cells, but it also downregulates the inflammatory process. So it's not just only blocking when the histamine release, it also blocks the other uptake from the other cells and reduces inflammation from there. So that's a multiple pathway from the use of antihistamines.
Thank you so much for giving us a big picture about allergic rhinitis and why oral antihistamine could actually help in this disease.
Absolutely.
And I also noticed that in this consensus is so unique because in this consensus we focus on patient profile. There are actually 3 profiles that I noticed in this consensus, namely the children, the adult, and the elderly. Could you actually help to elaborate on the children one and what should we actually take note from it?
Sure. I'd like to highlight certain key elements from this article. And the first thing when we approach the use of antihistamines in children, this article highlights not to use the first generation antihistamines due to the side effects. Second is we also highlighted that when you use antihistamines in children, a key factor is the taste of antihistamines.
That will indirectly affect compliance.
Correct. So taste and the method that is delivered is also very important, because in children there are chewables, there's syrups, there's quick dissolving tablets that are out there. But for ease, we only focus on the products that were available in Malaysia. So the key to the primary care physicians or the primary care providers is to realize the syrups come in different flavors and to be aware that certain children might prefer certain flavors over the other. Second is for picky children, they do not want to take the syrup directly, and you may have to hide it in other food products.
Because of the aftertaste, I think.
Absolutely. So in fruit juices, in ice cream, in yogurt. So the articles also highlights that if you want to do that, certain antihistamines are not appropriate for mixing with fruit juices because it can decrease the absorption of that antihistamine. So it's very nicely highlighted. Also, this article also discusses about in children the use of antihistamines, the duration, which we will get about to this in a later part of this interview about the duration of use of antihistamine. Because parents always want to ask, is it safe? You know, how long should I use it? So the key in children is in this article is certain antihistamines, especially loratadine and cetirizine, has been used for prolonged periods of time and has a vast data of safety profile.
Thank you so much for sharing a little bit about the children. And what about adults?
Okay, for adults, we usually divide adults into childbearing females and normal usual
working
adults.
adult.
Yeah, working adults. So usually when we approach first the childbearing female adults of the age, we want to choose an antihistamine that has the best safety profile for pregnancy and also safety for the child when the fetus is in the body. Of course, we all know that the best medication during pregnancy is no medication, right?
Yeah, exactly.
So, but if you have no choice, right, you want to choose an antihistamine that has the best profile, that has the longest data of safety and use, and we do not want to use the first generation antihistamines, so we want to use the second generation antihistamines. And again, we note that loratadine and cetirizine are the 2 antihistamines that have the longest safety profile, especially in pregnancy. And the thing a lot of people will think about, well, you know, I wasn't planning to get pregnant, so it's okay. But you know what? Pregnancy can happen at any time. Nobody really absolutely plans for pregnancy. It just happens, right? So you want to have, when you approach this patient profile, at least you have some thought on the antihistamine that is being used.
All right. Thank you for sharing about the pregnancy group.
Yes.
How about
the regular adult group?
Yes.
Okay. So the working adult group is very important to choose antihistamines that are non-sedating. And also you want to avoid the first generation antihistamines, especially in the elderly, because they have dementia, they are prone to falls, and they have a lot of undesirable side effects when you use first generation antihistamines in the elderly. So if you look at it, the message is very consistent. No first generation antihistamine, no first generation antihistamine. But we go into it in this article based on the patient profile, and we say why you wouldn't want to use first generation antihistamines. Of course, in the clinical practice, there may be some instances where the clinician may want to choose a first generation antihistamine, but at least this article highlights the risks when you are using it on certain patient profiles and what you want to look for when you want to use a first generation antihistamine. So for working adults, you want to use an antihistamine that's effective, that is non-sedating, and that is long-acting, that has a great safety profile as well.
Thank you so much, Dr. Kent, for sharing the patient profile. And Dr. Kent, one of the most common concerns as a healthcare provider are how long could they actually prescribe the oral antihistamine? Could you actually help us to shed some lights on this, the long-term usage of oral antihistamine, or should we use it for short-term? And is there any differences between perennial and seasonal allergic rhinitis?
Absolutely. That is a very, very important question. I alluded to this earlier, but I held back because we want to save the best for last.
Yeah.
Right? So truly, there is no real answer for how long you could use an antihistamine safely. The reason why we can use it for long term is that the safety data profile are very excellent for the current antihistamines that are being used. That's why we rather approach the antihistamine based on the patient profiling. Some things that must be considered when you are thinking of using antihistamines is the renal function and the hepatic function. Those are the two
clearance.
Yes, yeah, the hepatic and renal clearance. Those two things must be at the back of your mind because certain antihistamines are cleared renally, certain antihistamines are cleared hepatically, certain antihistamines use both of those mechanisms of clearance. So when you want to use an antihistamine for prolonged period of time, and also especially in the elderly, you want to bear in mind the hepatic and renal function before you prescribe the antihistamine. After having said that, most data and most studies have studied antihistamine use for up to 18 months. 18 months is a year and a half of continuous use. I don't know about you, but I never am able to take a medication that long, really, right? So if you ask me to take a vitamin every day, I'll take it in a week, maybe 2 or 3 days, and then I'll forget the rest. So truly, I mean, to be that compliant is really rare. But certainly we do have patients that are very, very compliant. They make a schedule and they follow it to the T. So for those patients, you know, the data suggests that we save up to 18 months. But from clinical practice, and you ask a lot of the opinion of people out there, the use of antihistamines, especially in chronic urticaria, where we use high doses, up to 4 times the approved dose, we have used it for up to 5 years, 6 years, 10 years, because you need to suppress the urticaria, and the goal for urticaria control is for complete control of the symptoms. And one tablet a day may not do the trick. So in these circumstances, in these diseases, you have used it for prolonged periods of time, and based on my clinical history, in terms of experience, both myself and my colleagues, it has shown extremely good safety profile. Nevertheless, I will never, how would I say, recommend. You just say, come in, here's your pills, see you in 5 years later. I do not recommend that, right? So what we do is like we have scheduled routine follow-ups. If necessary, we do blood tests.
Titration.
We also taper the medications if we can. So that hopefully helps answer the question. First is we do have data published up to 18 months. We do have clinical experience from many colleagues, many experts that have used antihistamine high dose for many years without any problems. And the recommendation is if you intend or need to use those medications for prolonged period of time, to have scheduled regular follow-ups and to at least check the renal and hepatic function from time to time to make sure you're not missing anything. Now, after having said that, the treatment for allergic rhinitis, especially for perennial allergic rhinitis, which is essentially what we see here in Malaysia, because we have only 2 seasons. It's either raining season or non-raining season, right? Or durian season or non-durian season. There's only 2 seasons. But really for us in Malaysia, we are perennial allergic rhinitis. And our number one enemy for allergies is the house dust mites. You sleep with them every night. It's in your pillow covers, your blankets, your bed sheets. So you are exposed to the dust mites every night when you sleep. So we are using treatment for perennial allergic rhinitis, and you need the antihistamines. You need to use it for prolonged periods of time. You can't take it for 5 days and expect the allergic inflammation in these perennial allergic rhinitis to go away, right? If you take 1 or 2 days and it gets better, you want that person to maintain taking it for 2 to 3 months, in my experience, for the severe diseases, so you can lower the allergic condition, the allergic inflammatory process in the nose. And at the same time, you need environmental control. So it doesn't matter, you know, if you take antihistamines and your symptoms are better, but you're not removing the source of the symptoms. So you got to do the house dust mites control, and you have to be diligent. So by doing that, you reduce the allergen load, you reduce the inflammation, and that's where you get a really good response. So I hope that helps our listeners out there.
Another thing, Dr. Kent, just an add-on question, since you mentioned that exposure control is very important, do you think that nasal saline would definitely help this group of patients besides medication in order to reduce the exposure to?
Absolutely. So nasal saline actually helps flush the allergen that's sticking into the mucosa of the nose. So by doing that, you'll reduce the symptom and also reduce the allergen load in the nasal mucosa. That really helps. Yeah.
All right. Thank you so much, Dr. Kent, for sharing a very thorough information with us, and also a little bit of insights about the journal. And if all of you are actually interested, do look into the journal. But before that, I would like to ask if there's any keyword or takeaway which you would like to share with the audience that you would think that would benefit them in their clinical practice.
Absolutely. So I already know that the listeners out there are going to be diligently reading the article. So I'm going to share some nuggets that are not being talked about in this article. The first is that in severe allergic rhinitis, that is not responding to antihistamines. I want the listeners out there to consider what we call the united airway disease. And in these circumstances where you are only treating the upper airway and you are ignoring the lower airway. So the united airway disease says that allergic rhinitis and asthma are related. So if you have allergic rhinitis that somehow do not respond to treatment, you may be missing asthma. You were not picking up asthma. So if you're treating only the upper airway without the lower airway, then your upper airway is not going to respond as well as you want. So that's one nugget that I like to share with our listeners out there, that in severe allergic rhinitis, do think about asthma and do evaluate for asthma in these circumstances. If you treat the asthma with the allergic rhinitis, you're going to have a much better outcome. So the other thing I want to share about with this antihistamines is in the use of antihistamines in food allergic reactions, especially have anaphylaxis. I think everyone says, you know, I have a food allergic reaction or there's anaphylaxis. The first thing that we reach in is an antihistamine. There's nothing wrong with that, but I want to share this information out there, is that when you have severe anaphylaxis, fatality can happen within 15 to 30 minutes in these patients with severe food allergy, with food allergic anaphylaxis. And if you reach for an antihistamine, the antihistamine only peaks in action within 1 hour. So antihistamines should be thought about, but should not be the first line treatment for anaphylaxis, especially in food allergy. For these patients, you want to remember about epinephrine and to counsel these patients to have a auto-injectable epinephrine with them, an EpiPen. to carry with them. Because an epinephrine, once injected in your body, you get a maximum effect within 5 minutes. So absolutely is the mainstay treatment for anaphylaxis. Antihistamines is an adjunct treatment. You don't want to ignore using antihistamines, but you don't want to use antihistamines and ignore the use of epinephrine. So please remember, for all our listeners out there, for patients with food allergy, make sure they have epinephrine available because that is the mainstay treatment for anaphylaxis. I hope that helps.
Thank you so much, Dr. Kent, not just sharing about this journal, but also the pearls and some of the pitfalls based on your clinical experience. And I'm sure that the audience do value this as much as I do. And once again, thank you so much, Dr. Kent, and we have come to an end of our episode today, and we hope to see you in our next episode. Thank you so much.
Thank you for the invitation.
Bye.